Hello, good morning everybody. বেসিক্যালি আজকের এই প্রোগ্রামটা তো একদম আমাদের এখানে খুব অভিনব এবং নতুন। এরকম প্রোগ্রাম আগে হয়েছে বলে তো আমার মনে পড়ছে না। তো এই উদ্যোগটা যারা তোমরা নিয়েছো, স্পেশালি ডক্টর মজুমদারের আন্ডারে থেকে এবং সবাই মিলে করে, এটা অভাবনীয় এবং আই অ্যাপ্রিশিয়েট দিস এফর্ট ফ্রম অল অফ ইউ। এখন এইরকম যদি ডিসকাশন সবাই মিলে করা যায়, তাতে ইনপুট ফ্রম দ্য আদার ডিপার্টমেন্টস অলসো, যেমন সার্জারি, যেহেতু এটা জিআই ট্র্যাক্ট নিয়ে ওরা তোমরা বলবে, সার্জারি বা মেডিকেল অঙ্কোলজিরও এর মধ্যে রোল থাকে, এবং অবশ্যই রেডিওথেরাপি। তো আজকে রেডিওথেরাপি স্পেশালিস্টরা এবং মেডিকেল অঙ্কোলজি স্পেশালিস্টরা এখানে নেই, যেহেতু আমাদের সেকেন্ড ক্যাম্পাস আরেকটা প্রোগ্রাম আছে। তো এনিওয়ে, এটা ইটস আ গুড এন্ডেভার, এবং আমি আশা করব ভবিষ্যতে তোমরা আরো এরকম করবে, so that we can all participate and in a bigger platform in আমাদের auditorium. তাহলে the participation will be more and everybody can get more. Thank you and best of luck for this program.
Next, our honorable request to our Dr. Aniruddha Ram. Sir, please come here and say something.
Thank you so much for keep it very brief. This is a scientific discussion, and I look forward to inputs from your end, because all of you doing a structured program, as your mentor and head of department of radiology, Dr. Shubham said. You people are here for a 2-year course, so we'd like to hear what you are doing and how much it can help our patients. I'll keep it short. I expect the speakers to take up the rest of it. Thank you.
Next, my request to our Sir Dr. Kumar Bhumi.
Good morning everybody. ম্যাডাম আমাকে বললো যে এরকম একটা সেমিনার হচ্ছে, আমাদের স্ট্রাকচার প্রোগ্রাম আছে। তো শুনে খুব ভালো লাগলো। এই ধরনের প্রোগ্রাম চাইতে এরকম ভাবে এখনো মানে এর আগে হয়েছে বলে মনে করতে পারি না। তবে এই ধরনের প্রোগ্রাম সবারই একটু শুনলে সবারই লাভ হবে। আমরাও কিছু হয়তো, কারণ এগুলো পুরনো যে টপিক গুলো বলা হবে সেগুলো বেসিক সায়েন্সের উপরে, সো সবাই শুনলে সবারই লাভ হবে। হ্যালো, তো এখানে সব ডিপার্টমেন্টকেই মানে তোমরা তোমাদের তরফ থেকে বলা উচিত, কারণ মেডিকেল সায়েন্স কোনো একটা পার্টিকুলার ডিপার্টমেন্টের হয় না, সবার সঙ্গে সবার ইন্টারলিঙ্ক। সেই জন্য আমরা হেড অ্যান্ড নেক অঙ্কোলজি থেকে এসেছি, সার্জারি, রেডিওথেরাপি এবং রেডিও ডায়াগনোসিসে ম্যাডাম এসছেন, রেডিওথেরাপি, মেডিকেল অঙ্কোলজি ওনাদের দেখতে পাচ্ছেন, কিন্তু তারাও এলেও ভালো হবে, তারা সেগুলো শুনলে। এবং এই ধরনের স্ট্রাকচার প্রোগ্রামে সবারই অনেক কিছু শেখার আছে, তোমরাও আস্তে আস্তে এগুলো ইমপ্রুভ করতে থাকবে। আজকে জিআই ট্র্যাক্টের উপর কিছু বলা হবে, জিআই ট্র্যাক্টের অ্যানাটমি, ফিজিওলজি এসব। তো আমরা এবার শুনি আর কি, শুনে কিছু লার্ন করি। ওকে,
Thank you, sir. Our honorable request to our HOD, Dr. Suparna Mujumdar ma'am, to sharing her knowledgeable experience with us.
I feel very happy today. I'm very proud that the room is filled with our students. Some of them ex-students, and some of them will leave and become my ex-students, work in good places. We are happy that we have been running this service for a long time in CNCI. We have produced many radiographers and radiotherapy technicians. It is indeed, we are running silently. I don't even realize. It's good that you talk about other clinicians, because many of them don't realize all the back-end work that goes on in these departments. And they are a very important part of the departmental fabric. Without them, it's difficult to provide services to the patients. Today that they have come and they are showing their faces, usually their faces are behind closed rooms, closed doors. Many of you don't see them and realize that they are there. So their existence to the working of a hospital is so important in day-to-day clinical work. And we'll try to make sure that next time it happens, more clinicians could be present. Unfortunately, today there is a clash of work for the other departments. এই জন্য তারা আসতে পারেনি আমরা সেজন্য we are a little sad that this program was prefixed. Anyway, I'm happy that my students have come forward. They're taking up this challenge, and I think that today's program will also be a lesson for them in the future. So that wherever they go, science is just a stopover where they learn. They have to move forward. সামনের যে জগতে তারা যাবে, জগৎটা খুব কঠিন। সেখানে যাওয়ার জন্য যে সেলফ এস্টিম, কনফিডেন্স লাগে, আমার মনে হয় এই যে আজকের প্রোগ্রামটা তাদের কনফিডেন্সকে আরো বাড়িয়ে দেবে। এটুকু বলে আমি আমার কথা শেষ করছি। থ্যাংক ইউ। প্লিজ গো ফরওয়ার্ড।
Thank you so much, ma'am.
Alokda?
Today's our CME based on GI tract. GI tract also related to mouth. We take food by mouth, survive by food. Food. Each letter in food is stand for fruits and veggies. First, O is stand for organic lean protein. Second, O is stand for omega and fatty acid. D is for drink water.
Every species needs water. We all know about that. But besides the water, food is so important to us. It gives us energy to function and maintain the bodily process that keeps us alive. My co-host Susmita already said that the food is taken by oral cavity and excreted by anal canal. Today, we all gather together discuss over GI tract, and our CME started with our student first year, Sukarna Patro. She will describe the anatomy of esophagus.
Good morning, everyone. I am Sukarna Patro, the student of first year of Tier 2. Today, I am going to discuss of anatomy of esophagus with diagram in a simple way. It is a very important part of our digestive system. So, let's start our discussion. What is esophagus? Esophagus is a narrow muscular tube which is forming food passage between the pharynx and stomach. It also known as food pipe. Now, I saw what is the situation of esophagus. Esophagus begins at the inferior border of the cricoid cartilage, that is at the level of C6, and its end at the cardiac orifice of the stomach, that is at the end, that is at the level of T11. What is the length of esophagus? It is about 25 centimeter part. It has three parts: cervical part, thoracic part, abdominal part. Cervical part begins from the lower border of cricoid cartilage and ends the superior border of manubrium sternum, length 4 centimeter. Next, thoracic part begins from superior border of manubrium sternum and it ends the esophageal opening in the diaphragm, length 20 centimeter. Abdominal part begins at the esophageal opening of the diaphragm and it ends at the cardiac end of the stomach, length 1.5 centimeter. Now I goes to constriction. It has 4 constriction. First constriction at the pharyngoesophageal junction at C6 vertebral level and 15 centimeter or 6 inches distance of upper incisor tip. Second one, it is caused by the arch of aorta at T4 vertebral level, distance 22.5 centimeter or 9 inches from upper incisor tip. Third one, it is crossed by the left principal bronchus, the T5 to T6 vertebral level, 27.5 centimeter or 11 inches from upper incisor tip. Fourth, it pierces the diaphragm at T10 vertebral level, 40 centimeter or 15 inches from upper incisor tip. Next, this is the diagram in constriction of esophagus. Next, I discuss how many structure of esophagus. Two side-to-side curvatures. Two side-to-side curvatures, both in the direction of the left. First, at the root of the neck before entering the thoracic inlet. Second, at the level of T7 vertebra before passing in front of the descending thoracic aorta to anterior-posterior curvature. First, corresponding to the curvature of cervical spine. Second, corresponding to the curvature of thoracic spine. Now, I saw anatomical relation of esophagus. Cervical part, anteriorly trachea, posteriorly the right carotid sheath and its contents. Left side, the left recurrent laryngeal nerve, the thyroid gland, the left carotid sheath and the thoracic duct. Thoracic part, anteriorly trachea, left recurrent laryngeal nerve, posteriorly thoracic vertebral bodies, thoracic duct, and azygous veins descending aorta. Right side pleura, terminal part of azygous vein, and left cervical clavian artery, aortic arch, and thoracic duct and pleura. Abdominal part, left vagus nerve, posteriorly surface of the heart, posteriorly right vagus nerve, left curves of the diaphragm. This is the diagram of anatomical relation of esophagus. Here I describe about structure of esophagus from outer to inner. Fibrous cord. It is free from the muscle cord to allow distension of the esophagus. Muscle. Outer longitudinal muscle continuous with that of stomach. Inner circular muscle condensed hair forming physiological cardiac splinter preventing regurgitation from stomach. Submucous coat contains esophageal glands and mucous membrane. Splinter. There are two splinters, the upper esophageal splinter and the lower esophageal splinter. The upper esophageal splinter acts to prevent the entry of air and the lower esophageal splinter reflects of gastric contents. Esophagus also have blood supply, nerve supply, and lymphatic, arterial supply. By the esophageal branches of the inferior thyroid artery, esophageal branches of the descending thoracic aorta, of the left bronchial artery and the left gastric artery supplies the thoracic part. The left gastric and the inferior phrenic artery supplied by the abdominal part. Venous drainage. Cervical part is drained by the inferior thyroid veins. Thoracic part drains by esophageal veins draining into azygous vein, hemiazygous vein, left gastric vein. Abdominal part is drained by the left gastric and inferior phrenic veins. Lymphatic. The lymphatic drainage of the esophagus divided into thirds. superior third deep cervical lymph node, middle third superior and posterior mediastinal nodes, lower third left gastric and celiac nodes. Nerve supply. Recurrent laryngeal nerve supplies the cervical part, thoracic splenic nerve, anterior-posterior gastric nerve, sympathetic plexus at the thoracic and abdominal part also. Now I think the function of the esophagus. It acts as a passage of food from oral cavity to stomach. Let's see some applied anatomy. Short esophagus. In such case, stomach lays in the thorax. There may be absence of esophagus, aphasia, tracheoesophageal fistula, gastroesophageal reflex, eosinophilic esophagitis, Britter's disease. At the last of my presentation saying the investigation of esophagus, chest x-ray, barium swallow, esophagus, CT thorax for esophagus, upper GI endoscopy. It is choice because we can see the esophageal mucosa and it can done by the GI endoscopy. So I finished my PPT presentation by saying thanks to all my teachers, batchmates and seniors to help and to guidance me. Thank you.
I would like to thank you so much for your presentation. Thank you so much for your hard work. This wonderful event can't be possible without our HOD, Dr. Suparna Mojumdar ma'am of our radiological department.
Before call next contestant, I would like to say a few words about GI tract. Gastrointestinal tract in an adjective meaning of or pertaining to the stomach and intestine. It also called digestive tract or alimentary canal. The gastrointestinal is the tract or passageway that leads from the oral cavity to the anus. It contains all the major organs in human, including the esophagus, stomach, and intestine. Food taken in through the mouth is digested to extract nutrients and absorb energy. The waste expelled at the anus as feces. Next, we welcome Sadia Sabnoor for describe about radiological investigation of esophagus.
Good morning, everyone. Taking preference to introduce myself, I am Sadia Sabnoor, second year of DRT. Today, we are discussing the GI tract. Now, I am talking about the method of imaging the gastrointestinal tract. Under X-ray, plain film, barium swallow, barium meal follow through, small bowel enema, barium enema. Under USD, transabdominal or endosonography. Under CT scan, CT enterography for diagnosis of Conn's disease. Before going to my main PPT, I will discuss the barium. Actually, barium is a radiographic contrast agent. The contrast agents are used to visualize lumen of GI tract. Why we choose barium as a contrast? Because it is radio opaque, it is highly atomic number, or it is non-toxic. Advantage using of barium. It is non-absorbable, non-toxic. Now I am Now I am discussing my main PPT. My main topic is contrast study of solo studies of esophagus. It is investigation of esophagus, investigation dysphagia, contraindication, assessment site of perforation, assessment the tracheoesophageal fistula. Contrast medium. They are used barium microbar powder, LOCM aspiration or fistula, tracheoesophageal or gastrografin for perforation. Patient preparation. There is no such patient preparation. Equipment under fluoroscopy unit. Technique. Cervical AP for bilateral PFS. Cervical lateral for vasomolar valiculi. Aleo, right anterior oblique position to clear up spine. Start with the patient in erect position. One mouthful of barium paste is given and under fluoroscopic observation of the act of deglutition in full length AP or PA view for thoracic and abdominal part of esophagus. The patient is placed semi-prone in a LPO position to demonstrate hernias, subdural mucosal ring and esophageal varices. Modification of technique. Foreign body impaction to detect the level of obstruction in case of radiolucent foreign body in the esophagus. A marshmallow coated with barium or cotton soaked with barium can be swallowed. Tracheoesophageal fistula. Known case of tracheoesophageal fistula. In that case, we use gastrography because gastrography is a contraindicated. Gastroesophageal reflux. Fill the stomach with 50% barium. Follow this. 1 mouthful of water to remove traces of barium in the esophageal varices. Keep 1 mouthful of water exit. Esophagus. Keep 1 mouthful water exit. Complication. Leakage of barium from unknown perforation. Aspiration. After care, eat and drink as normal but with extra fluids. Now we see the esophagus in X-ray with barium. Now we see the pathological X-ray in barium. This is aplasia cardia, a rare disorder which make difficulty to swallow food and liquid into the stomach. It is damaged nerves of the esophagus and preventing the squeezing food into the stomach. Next, it is the gastroesophageal reflux. Image of gastroesophageal reflux. It occurs when stomach acid persistently flows back up into patient's mouth through the esophagus from the stomach. Thank you.
It was a pleasure to listen to your presentation. Thank you so much, Shadia. Next participant is from radiotherapy department. We will narrate the treatment of esophageal disease. Neha Pakre, please come.
Good morning, sir and ma'am. Myself, Sneha Pakre. I am presenting role of radiotherapy in esophageal cancer. Anatomy of esophagus. The esophagus is 25 centimeter long fibromuscular tube extending from the pharynx at the level of C6 to the stomach at the level of T11. Esophageal cancer is the 6th to 8th most common cancer worldwide and 7th most common cause of death. So the mortality rate is very high, almost 0.88. Risk factor of esophageal carcinoma. There are so many risk factors of esophageal cancer. Gastroesophageal reflux is the common cause. Another one is obesity. Alcohol and tobacco is one of them. Sign and symptoms. There are so many sign and symptoms of esophageal cancer. The main and primary symptoms is oesophagia, which is pain during swallowing. Dysphagia, difficulty in swallowing. Weight loss is happen generally because of lack of food taken by the patient. Hematomesis, epigastric pain, regurgitation of undigested food. Histopathology. The most common histopathological subtypes are squamous cell carcinoma and adenocarcinoma. Rare types are neuroendocrine cancer, lymphoma, and sarcoma. Modality of treatment. Surgery is the principal curative therapy, but chemotherapy and radiotherapy have distinct roles in the treatment. Pre-operative chemoradiation leads to a survival benefit of 13% at 2 years. Radiotherapy. Workflow of radiotherapy. The first and most important step is patient selection and counseling is followed by CT simulation. Then tumor and OR delineation is done by doctor. After that, treatment planning is done by medical physicists. Plan optimization and evaluation is the most important part. TBH is the tool for plan optimization and evaluation. Proper QA is done before start of treatment. After proper QA, treatment is delivered. CT simulation. The patient position should be supine. Patient must be lie in the comfortable position because reproducibility is very important for everyday radiotherapy treatment. For cervical esophagus, thermoplastic mold is used as immobilization device. For thoracic esophagus, we use vacuum cushion. Tumor and OR delineation. GTV or gross tumor volume is visible and palpable tumor. Clinical target volume or CTV is derived using 2 cm margin in superior and inferior direction and 1 cm in circumferential direction. Planning target volume or PTV is included using margin of 1 cm superior and inferior direction and 0.5 cm circumferential. PTV is added due to setup error or uncertainties of the setup. As you can see in the image, the proper delineation of GTV, CTV and PTV, which has been discussed in the previous slide. The lymphatic drainage of cervical esophagus are internal jugular, cervical or supraclavicular node. For thoracic esophagus, it may supraclavicular, paratracheal, mediastinal, gastric, celiac axis nodes. There are so many OR near the PTV like heart, lung, spinal cord. Treatment technique. In 3D CRT, we use APPA portal and oblique portal. The aim of radiotherapy is to deliver maximum dose to the tumor and minimum dose to the surrounding normal tissue, which is active by IMRT. IMRT is intensity modulated radiation therapy by which a non-uniform fluid is delivered to the patient from any given position of the treatment beam to optimize to composite dose distribution. With this technique, a highly conformal dose can be delivered to the tumor with surrounding normal tissue sparing. IGRT or image guided radiotherapy. CBCT is taken before each day of the treatment. The image is matched with the image of CT simulation. In the slide, we can see the KV extra tube and the detector. The KV extra tube rotated around the patient and volumetric image is reconstructed. The CBCT image is matched with the CT reference image to check the patient alignment, tumor progression, regression is there or not. In the image we see the CT image is matched with the CBCT images. Then we get shift in lateral, longitudinal and vertical direction. Then we apply the shift and treat the patient. In case of neoadjuvant chemoradiation, 40.1 grade dose is delivered in 23 fraction and boost dose is 9 gray in 5 fraction. In case of concomitant radiotherapy, 50 gray dose is delivered in 5 fraction in a week. Patient care. During treatment, dietary assessment and nutritional support are an essential component of the management. Thank you.
On behalf of the CME member, I want to thank you for your insightful presentation.
I would like to express our special thanks to our mentor, Senior Technologist Alok Roy, Senior Technologist Komor Ghosh, Technologist Devopratim Das, and Technologist Somrat Chakraborty for their valuable time and efforts that which they provide.
Without our respective teacher help to make this CME can't be possible. In this aspect, we are eternally grateful to all of you, sir. Now we request to call Lubna for her presentation. We will discuss about the anatomy of stomach.